Today my topic of discussion is on how I have incorporated immediate implants in my practice. I will be sharing a couple of cases that I initially started off with. I have a guided implant workflow and a trio scanner with which I take impressions for the digital guide and for the crown. The first case is a 49-year-old healthy male who wanted to replace his lower broken left premolar. At that point in time, I was not very familiar with immediate implants. All I knew was socket graft, get the patient back in 4 months. Sorry. And this is the socket grafting that I had done. The patient came back 4 months later, and he had pain in his 3/6, so root canal was done. The patient said, now give me some more time and I'll come back in a while. Patient came back almost a year later and said, I'm all ready. You can go ahead with the implant on 3/5 and a crown on 3/6. We took a CBCT and lo and behold, this is what we saw on the CBCT. There was a huge infection here on 3/6. Now I had to make a decision whether to extract or re-treat this. I spoke to the patient and gave the patient options. And patient decided to go ahead with the extraction because he said he didn't want to retreat it. We were anyway placing an implant in 3/5. The most important thing I've realized while selecting cases is patient expectations. Have an open communication, explain to them the pros and cons, under-promise, over-deliver. So that's exactly what happened with this particular patient. He agreed and we went ahead for implants. Implant on the 3/5 and an immediate implant on the 3/6. This is the guided report because I do a lot of guided surgery, just like Reena. And these are the impressions, the CBCT files are uploaded, and this is the surgical stent. This is the day of surgery. Atraumatic extraction of 3/6 as much as possible. I first started off with the extraction of 3/6. The surgical guide placed, the hyosin implants, ED4, the healing abutments, the jump cap filled with bone, the membrane, PTF sutures, double interrupted sutures. This is just a slide showing how I extracted the mesial and the distal roots. I love using the long surgical round diamond burrs to debride and clean the sockets, just like one of our colleagues said. Clean, thoroughly clean until you see real white. So that's what I did. The pre-op x-ray over here, where the 3/5 implant went in, the 3/6 that was extracted, these are the two implants with the healing abutments. I usually love taking pictures on the day of surgery, 1 week post-op, 1 month post-op, and 4 months. 1 week post-op, what I usually like to look for is the sutures, whether they are in place, the oral hygiene. Stress with the patients not to trouble the immediate area site, keep the tongue away, at least for the first 6 weeks. Check on the healing abutment. 1 month later, I like to make sure the site is healing well, they're maintaining oral hygiene, the sutures are removed too, and I usually take an x-ray to just check what's going on with the bone. This is 4 months later when the patient comes in, and I've removed the healing abutment. This is the emergence profile. This is for 3/6 and this is for 3/5. I'm sorry, it's the opposite. And like I said, since I have the trio scanner, I use the scan bodies, that's the one over here, to take impressions. The scan body replaces the impression copings that you all use. And the most important thing while using the scan body is the flat end surface facing towards the buccal. I have tried to show it after taking impressions that it's more towards the buccal. The second important thing is once the scan bodies are placed, you take x-rays to make sure that they're seated really well. And these are the crowns, scromentable Shaw zirconia crowns, custom titanium abutment, 2 of them that I usually get them done from Shaw Lab. The occlusal view, the buccal view, and the finished case. Happy patient, happy dentist. Patient is now motivated to do his upper 1516 next year.